The following is a UTI case study by Amanda UTI and Liz Westberg for Advanced Pharmacology NUR 601. Today we are seeing Betsy, a 30-year-old lactating female. 5 days ago, Betsy started feeling discomfort with urination. She increased her hydration and added cranberry juice to her diet. Betsy prefers natural remedies and has started also taking bearberry leaf uva ursi tea, but she has had little to no relief. The discomfort has now progressed to pain. She reports a 7 out of 10 level of pain with urination, as well as increased frequency and urgency, along with difficulty emptying her bladder. She denies hematuria and flank pain. She presents to the office today for a suspected UTI. She is concerned about the use of antibiotics as she's still breastfeeding her 18-month-old son Forrest and does not want him to have any negative effects from the medication. She does not think she is pregnant, but she cannot recall the date of her last menstrual period. Let's review Betsy's social and medical history. Betsy is a stay-at-home mother who states she uses the rhythm method for contraception as she is concerned about hormonal contraceptives. She is sexually active with her husband Jason and reports being in a monogamous relationship with him. Her past medical history is as follows: a tonsil and adenoidectomy at age 6. She had a right elbow fracture that required surgical setting and multiple pins placed at age 10. She is gravida 1, para 1, delivery by C-section due to failure to progress post-induction at 42 weeks at age 28, and she currently takes just a postnatal multivitamin. Let's discuss Betsy's reported symptoms with our assessment and testing method to help Betsy get some answers. Betsy reports discomfort, burning, a pain level of 3 to 5 out of 10 with urination for the past 5 days, but today her pain is increased to a 7 out of 10. She has increased frequency of urination with only a small amount during each voiding session. She complains, and I quote, "I can't empty my bladder," end quote. She denies flank pain or hematuria. She has tried cranberry juice and uva ursi tea with little to no decreased symptoms. Upon my assessment, her vitals are as follows. Her blood pressure is 124/80 with a heart rate of 70. Her respiratory rate is 18, and the patient is afebrile at 98.5 oral temperature. We decided to do a urine dipstick test, a pregnancy test, and a urine culture. She has suprapubic tenderness upon her examination. And the results are in. The urine dipstick test showed positive leukocyte esterase, low-grade proteinuria, and positive for nitrites. Her pregnancy test came back positive. This is a surprise to the patient. We will circle back to this with the patient and offer support, as this could be a shock to her. We want to allow her to take a breath, maybe a minute to digest this. We need to assess the situation and make sure she is good to continue before proceeding with a discussion about her current results that are leaning towards UTI and antibiotic treatment. The urinalysis culture will give us a bacteria once it has grown out in 24 to 48 hours. For the sake of this case study, we are able to predict the future, and we see the culture shows gram-negative E. coli. E. coli is the most common cause of UTI and accounts for approximately 70 to 80% of all cases in pregnancy. Something to consider, though she is early in her pregnancy, the two are most likely mutually exclusive. No imaging studies for renal ultrasound is indicated at this time. Let's now discuss Betsy's differential diagnosis. Our leading hypothesis is that Betsy is suffering from a lower UTI or acute cystitis. This involves the lower urinary tract system, the bladder and the urethra, and results from bacteria entering the urethra and or bladder and causing an inflammatory response. The signs and symptoms are hematuria, dysuria, suprapubic discomfort, frequency and urgency, and nocturia. We must not miss an acute pyelonephritis or an STD. Acute pyelonephritis is the most common urinary tract complication in pregnant women occurring in 0.5 to 2% of all pregnancies. The signs and symptoms are fever, flank pain, and significant bacteria. In some cases, nausea, vomiting, frequency, urgency, and dysuria. Most cases of pyelonephritis occur in the second and third trimester. Betsy is not presenting with any of these symptoms. However, a lower UTI can lead to this. This is another point to stress to Betsy why we want to treat now and then to monitor throughout her pregnancy, because a UTI is a risk factor for developing another UTI or a pyelonephritis. Do not miss the possibility of a sexually transmitted disease like chlamydia, as the patient is a sexually active female with dysuria. However, this is not where we will focus based on the patient's social history of being married and monogamous. Also, the patient is not having lower abdominal pain. She is afebrile with no vaginal discharge or bleeding. Let's discuss the definition of a UTI. A colony-forming unit, or CFU, is used in microbiology to estimate the number of viable bacteria or fungal cells in a sample. Acute cystitis, or a lower UTI, is defined as more than 1,000 CFUs per milliliter of urine. A pyelonephritis is defined as more than 10,000 CFUs per milliliter of urine, and asymptomatic bacteria is defined as more than 100,000 CFUs per milliliter of urine with no symptoms. The urinary tract is normally sterile. Cystitis represents an invasion of the mucosa, often by E. coli, that inhabit the area in and around the vagina and ascend into the bladder via the urethra. Because intercourse may lead to the transport of bacteria into the urethra, it is common in sexually active females. Cystitis also occurs in 0.3 to 1.3% of pregnancies, but does not correlate with asymptomatic bacteria. Pregnancy can increase the likelihood of UTIs through hormonal and various anatomical changes that promote urinary retention. This, paired with a short urethra, helps make UTIs the most common bacterial infection during pregnancy. At this time, we do not think Betsy's pregnancy is a factor in how she acquired her UTI. Rather, something to keep in mind, as once you have had a UTI, the risk will increase that it will recur. Something to watch out for. We have diagnosed Betsy with an acute cystitis. Let's now discuss the goals of therapy and treatment options. The goals of therapy are to eradicate the E. coli bacteria in the bladder and ureters and relieve Betsy's symptoms, while also addressing her concerns regarding taking oral antibiotics. We will help Betsy weigh the pros and cons of oral antibiotics and then make our recommendation. Oral antibiotics are the treatment of choice for acute cystitis. It will be important for the provider to stress to the patient the need to treat with antibiotics due to the potential for a UTI to cause a worse infection that could then complicate her pregnancy, including a pyelonephritis, preterm birth, and low birth weight. We will obtain a urine culture, as we do with all pregnant patients with suspected UTI, as the results may provide valuable information to the provider if the patient does not respond as expected to treatment. Pyuria and bacteria are always treated during pregnancy, regardless of whether the patient has symptoms or not. In the case of this patient, she does have symptoms, so hopefully she will be open to antibiotics to treat her acute cystitis. This may be overwhelming for Betsy to take in at this time, so we will practice with empathy and follow up with the patient. The following drugs are choices to treat Betsy's acute cystitis: Macrobid, amoxicillin, Bactrim, cephalexin, and fosfomycin.
Medications that should be avoided during pregnancy include tetracyclines due to adverse effects on fetal teeth and bones, aminoglycosides due to ototoxicity following prolonged fetal exposure, fluoroquinolones, which should also be avoided during lactation as they are toxic to developing cartilage, and trimethoprim sulfamethoxazole should be avoided during the first and third trimesters. Nitrofurantoin, or Macrobid, 100 milligrams twice daily for 5 days will be our prescription for Betsy. This is the first line of treatment for UTI in pregnancy. However, its use should be avoided at the end of pregnancy due to a theoretical risk of hemolytic anemia in the newborn. It's metabolized in the liver, excreted primarily in the urine, and has a half-life of about 45 to 60 minutes. Macrobid interferes with bacterial carbohydrate metabolism by inhibiting acetyl coenzyme A. It is bacteriostatic at low concentrations and bactericidal at higher concentrations. It inhibits DNA, RNA, protein, and cell wall synthesis. Several alternatives do exist as mentioned in previous slides, but they come with other side effects and some with a hefty price tag. This is cost effective at approximately $15 while also targeting her specific urine culture best. Some alternatives to nitrofurantoin do exist. If Betsy was in the late third trimester of her pregnancy, nitrofurantoin would be avoided. Also, if she were to have an allergy, this would, of course, be another reason to look at other drug options. We'd first consider a single dose of fosfomycin, but if this was contraindicated due to an allergy or adverse reaction, cephalexin or amoxicillin could also be considered. Amoxicillin should only be used if culture results are available and the bacteria is susceptible. Now it's time to provide some education to Betsy regarding the treatment of cystitis with nitrofurantoin. We'll explain to her that this is the first line of treatment for cystitis in pregnancy. We'll also stress to her the need to treat with antibiotics due to the potential for UTI to cause a worse infection that could then complicate her pregnancy, including pyelonephritis, preterm birth, and low birth weight. After discussing this, Betsy is agreeable to treating with antibiotics and feels much more comfortable. Nitrofurantoin is pregnancy category B. It's contraindicated at 38 weeks gestation and beyond, but it is safe at the stage of Betsy's pregnancy, which is estimated to be about 6 weeks. It is considered safe for Betsy to continue breastfeeding Forrest, although there are some minor risks to discuss. There is a possible risk of infant diarrhea and decreased milk production. This drug should also be avoided while breastfeeding an infant with G6PD deficiency or an infant less than 1 month old with hyperbilirubinemia. However, these do not apply to Forrest and therefore do not need to be discussed with Betsy at this time. We will then inform Betsy of common side effects: headache, dizziness, weakness, and drowsiness, as well as some GI issues including gas, indigestion, loss of appetite, and diarrhea. We will tell Betsy that although diarrhea is a common side effect, if she has severe stomach pains or bloody, watery stools, she should call us right away, as this could be a sign of C. diff, which would need treatment. Antidiarrheal medicines could make this worse, so we'll instruct her to call us before taking any antidiarrheal medications. We'll also instruct Betsy to take macrobid with food, even at bedtime, as this may lessen stomach upset, as well as help the body absorb the medication. We'll tell her to use the medication for the full prescribed length of time, even when symptoms subside, in order to avoid the bacteria becoming resistant to the antibiotic, causing symptoms to return. And of course, if symptoms do not go away, get worse, or get better and then recur again, we'll instruct her to call our office for reevaluation. We will next discuss some non-pharmacological treatment and considerations with Betsy. When Betsy first came in, she let us know that she was drinking cranberry juice in hopes that it would relieve her symptoms. Some studies done with daily high doses of cranberry, often in the form of pills or concentrates, have shown a 20 to 30% decrease in the rates of UTIs. This is an appropriate measure to take in the setting of recurrent UTIs. However, in the setting of a UTI already present, maybe not so effective. However, there's no harm in increasing cranberry juice intake or taking cranberry tablets or concentrates, and it may help prevent future UTIs for Betsy. She also let us know that she was drinking a naturopathic tea, uva ursi. Uva ursi is considered unsafe in pregnancy because it might start labor. Not enough data exists regarding its use in pregnancy for it to be considered safe. Additionally, no data exists on the excretion of any components of uva ursi into breast milk or on the safety and efficacy of uva ursi in nursing mothers or infants. Therefore, uva ursi is also generally considered to be contraindicated during breastfeeding due to this lack of data and its potential toxicity. We will also educate Betsy on wiping from front to back after urinating in order to avoid bringing E. coli from the anus to the urethral opening, thus introducing bacteria to the urinary system. We'll educate her to urinate after intercourse in order to flush out any bacteria, and also discuss avoiding spermicide, although this is not currently applicable as she's pregnant. Now it's time for follow-up. Betsy is excited about her pregnancy and initiates prenatal care with us as her family providers. Betsy takes a full course of antibiotics and her symptoms are relieved and there's been no recurrence. However, we will continue to keep an eye on this as it's not uncommon for UTIs to return. She reported some minor gas and nausea while taking macrobid, however is aware these symptoms could be associated with her early pregnancy rather than just the use of macrobid. If Betsy were to experience symptoms again, a repeat urinalysis and CNS would be indicated. However, at this point, no further follow-up is needed.